Excited to be here. I will try my hardest to get through everything I want to talk about in 30 minutes so that we leave time for some questions. But today I'm going to be talking to you about sleep. So, how can we sleep better so that you can live a better and more fulfilled life? I don't really need to introduce myself because Dr. Klaus did a great job with that, but I did want to reiterate that I am a clinical neuropsychologist at Virginia Commonwealth University. I am the director of Live Now, which stands for Neuro-Oncology Wellness. It truly is a program designed and developed for our patients and our caregivers, managing a brain tumor diagnosis with the mission of ensuring that we help you live a better and more improved quality of life throughout this trajectory. So what I'm going to be doing today is I'm first going to give you a brief background on what do we know about glioma and sleep. What also do we know about what can help with our sleep? What interventions have been trialed and shown to be effective? And then I want to wrap up with some really good strategies that I hope you can take away from this presentation and to hopefully start changing your sleep patterns starting tonight or tomorrow. And then describe an open trial that we have ongoing for insomnia if you are interested in participating. Okay, so quick facts about glioma and neuro-oncology. You are not alone. There are approximately 1 million Americans currently living with a primary brain tumor, and about 93,000 will receive an initial diagnosis this year. We know that there are many different types of primary brain tumors, actually over 100 distinct types, with the most common being gliomas. Oligodendroglioma, ependymoma, astrocytoma, glioblastoma, to name just a few. And we know that your journey probably started with one of these initial symptoms. Either you had a seizure, or you had a terrible headache, unlike one you had ever experienced before. You might have had weakness on one side of the body versus the other. You might have had difficulty communicating or been disoriented. But what we also know is that initial symptom that might have launched the trajectory of this brain tumor diagnosis is not the only thing that our patients experience through their disease. Many of our patients describe or report to us an ongoing symptom burden from the initial diagnosis throughout what they experience in their treatments. A really great study was done a couple years ago by Dr. Terry Armstrong. She looked at 600 patients nationally, and here's a whole long list of all the different symptoms that our patients were reporting struggling with. What I want to point out and what I find most interesting about this study is some of the very top reported burden symptoms were excessive fatigue and tiredness, daytime drowsiness and sleepiness, and disrupted sleep. And they also found that the symptom burden, so they were experiencing this tiredness, this sleepiness, this disrupted sleep, was the highest during and immediately following the treatments that they were receiving. So let's talk about what disruptions our patients experience that impact their sleep. So the first one is obviously the location of the tumor. We know that there are specific parts of the brain that help regulate our sleep and wake cycles. And this could be the frontal lobe, the brainstem, the hypothalamus, the basal ganglia, just to name a few. If the tumor is located in this spot and or pushing up against this spot, it can impact the way that we are sleeping. And then also, in addition to that, are the treatments that our patients undergo. So the first being that biopsy or the resection. So many of you guys are very educated on this. We want to go in and take out as many of those tumor cells as possible so that there isn't an opportunity for regrowth. But unfortunately, when they go in to take these out, they are cutting or possibly navigating around some delicate areas that might be really important for our sleep-wake cycles. So that might be impacting the way that we sleep where the resection took place. And then after the resection, most of our patients at some point in their trajectory go through very aggressive treatments, including targeted radiation therapy and also chemotherapy, which has a impact on the brain's functioning and also impacts the behaviors that that how do I say this? It impacts the brain network and it also impacts how we manage those brain networks. So we might put in behavior patterns into our day to day to deal with the cognitions that we're having, the thoughts that we're having, or the emotions that we're trying to regulate. And this disrupts our sleep wake cycle. And then as if that wasn't enough, on top of that, oftentimes our patients are prescribed medications that impact our sleep. So steroids might make us stay awake all night and or anticonvulsants to help keep those seizures away, which is a great thing, but also might make us drowsy during the day. So there's a whole host of reasons that our patients describe fatigue and poor sleep. So what I want to do now is I want to define not only what fatigue and sleep disturbance is for our patients, but also how many of our patients experience this. So fatigue is a subjective sense of physical, emotional, and or cognitive tiredness or pure exhaustion that's not proportional to what they've done through the day. So for example, I'll have a patient come into me and say, "Okay, I got up, I took a shower and I came to this appointment. Why do I feel like I just ran a marathon?" And with some of the latest research, it shows that up to 90% of our patients experience daytime fatigue at some point in their disease trajectory. Sleep disturbance is actually problems with initiating, maintaining sleep, having a short sleep duration, or perceive that their quality of sleep is not good. And up to 50% of our patients experience some type of sleep disturbance, which there is a whole host of them. We could have a whole didactic on the different kinds of sleep disturbance, from insomnia, which is the one that I see the most and actually treat, which is difficulty falling asleep, staying asleep, or waking up too early, to parasomnias, which is like night terrors or sleepwalking or sleep apnea, where you wake up and you're not actually breathing. So there's a whole host of different types of sleep disturbance. Again, with the insomnia, I see as most prevalent in our patient population. But more importantly than this, what I want people to recognize is that fatigue and sleep are some of the most frequent and severe symptoms that are endorsed by our patients with glioma. And more often than not, they're interrelated. So I have patients that come and say, "I'm not sleeping well, and so I'm fatigued during the day." And or "I'm so fatigued that I'm napping all day and then can't sleep at night." So they are impacting each other and most often come together in a pair. Now, why is sleep important? It is actually one of our day-to-day needs. Similarly to eating, to drinking, and to breathing, we need to sleep. It's when our body repairs and restores itself. It helps regulate our hormones and our immune functioning. It's when our brain consolidates memories and when it processes all the information that we have taken in throughout the day. And it help regulates our mood and help reduces our stress levels. So it does a lot of things. The analogy that I give to my patients when I try to explain the importance of sleep is I say, "Okay, I want you to think of your phone. You use your phone all day. We use our phone all the time throughout the day. And at the end of the night, what is the last thing we do often before we go to bed? We plug in our phone. Why do we plug in our phone? Because we need to recharge the battery so that when we wake up in the morning, it is a full battery and it will last the whole day so that we can accomplish everything we want to accomplish on our phone during the day. Well, I think about our sleep and our brain the same way. We need sleep to recharge our brain throughout the night. So then when we wake up, we are fully charged, we are alert, we are ready to take on all the tasks that we use during the day. So I think about our sleep as that battery recharging in our phone. And a question I get often is, how much sleep do I actually need? So this depends on the person, right? It's not a one size fits all, but for most adults, the general recommendation is we need anywhere from 7 to 9 hours of sleep, with actually Most people needing at least 5 hours of that core restorative sleep to feel rested the next morning. But there is a difference between the quantity of sleep, how much sleep we get, and the quality, right? They aren't always a one-to-one ratio. Just because we're sleeping doesn't mean we're getting that good restorative sleep. So what happens to us when we have daytime fatigue or we have sleep disturbance? The research tells us a whole host of negative outcomes are resultant. There's poor overall global health. We have an increased healthcare utilization, meaning that we go to the doctor more and we have more impact and negative medical incidences. There is increased psychological distress that happen when we don't get a good night's sleep, and increased cognitive impairment, which is over and above already the insults that happen after a brain tumor and or having treatments to the brain. This results in work limitations. I have patients that have such poor sleep that they cannot function during the day and cannot work. And then recent research is actually showing that we have now a social disconnection that happens. We stop saying yes to social activities. We stop engaging with those that we love, and we start spending more time isolated and in bed trying to recover from our sleep disturbances or daytime fatigue. And unfortunately, a recent study came out. This was actually done in Australia. It showed that only 20% of the neuro-oncology providers reported routinely screening for sleep issues in clinic, despite it being one of the highest ongoing symptom burdens our patients report. And so all of this being said, a couple years ago, some of my colleagues and I wanted to see what was going on inside my clinic. At VCU, was this a problem with our patients? To what extent? And are we helping to manage this? We found that 62% of our patients, which included those with glioma, reported poor sleep quality. We found that 22 of them actually met the clinical diagnoses for insomnia, and another 31% fell right under at that subclinical level, which we also know, if it's not treated, will eventually turn into clinical insomnia. But even more importantly than that, so that showed us there was a problem. But we found that 64% of our patients did not feel that their sleep disturbance was being well managed by their medical team, and that nearly half of them were interested in learning about behavioral treatment. So they would have participated or changed their behaviors around their sleep had their physician talked to them about it or offered them an intervention. Okay, so let's now switch gears. That was kind of my educational component. We know that this is a problem in our patients. We now know that it's actually not being treated effectively. What do we know about interventions that exist, and what do we know about them in our patients with glioma? So there's two different types of interventions for fatigue and sleep disturbance. The first is pharmacological, which is using medications to directly alter the brain's chemistry and alleviate the symptoms. And then there's also behavioral interventions, which is modifying your thoughts, emotions, and behaviors through either counseling or exercise or behavioral strategies around your sleep disturbance. And what do we know? What has been trialed in our patients? So a whole host of medications have actually been trialed, starting historically with benzodiazepines. These, while they help you fall asleep, they will actually, for lack of better words, knock you out. They actually have a lot of adverse effects. So they have daytime drowsiness, so a sedative effect that lasts throughout the day. They cause a significant dizziness, and they also cause memory impairment. So it kind of is known within the field that their adverse effects significantly outweigh the benefits, and these are routinely not prescribed as much when a person comes in and says they have insomnia. Antidepressants is something that is sometimes used with our patients. Again, it can be effective in helping you fall asleep, but there are also side effects. About 2/3 of our patients who are on antidepressants continue to report that drowsiness and fogginess throughout the day that they don't like. It's almost like they can't snap out of that sleep stupor that they were in. Some over-the-counter medicines have shown promise, including melatonin, which is more recommended for short durations when you're having some sleep challenges rather than long-term, prolonged use. Antihistamines also, like a Benadryl or something like that over the counter. Again, they are effective at helping you immediately fall asleep, but you do build a tolerance to them over time. And they are also more and more dangerous. The more you use, they become dangerous for those of us that have cognitive impairment. So actually, more recently, the advice from the Academy has been not to use the over-the-counter antihistamines for any sleep disturbance. The one that is growing, increasing interest in is the use of cannabis, especially as our regulations around the use of marijuana have changed in some states. About 2/3 of our patients that use marijuana say they use it for the sleep improvement qualities, and so they are reporting benefit from it. Although significant clinical trials have not been either completed or initiated yet. So there is a little bit of a warning around this that we don't know the true long-term effects of this, and we need to still continue to research it. Any of these medications that are either prescribed or over the counter, if used, I always recommend to my patients that they talk to their medical providers about it. We just want to ensure there's no contraindications with what they have you on. So the second types of interventions are these behavioral health interventions. So sleep hygiene is improving the regimens around our sleep, so the practices around our sleep. Physical activity, getting exercise has been shown to be very effective in helping us sleep at night. Mind-body interventions are starting to be researched, which are relaxation strategies, mindfulness strategies, and then cognitive behavioral therapy, which helps us change our thoughts and behaviors around our maladaptive sleep patterns. So I know we're on video. This doesn't work as well on video, but I usually do kind of a test right now where I ask people, what do you think right now is the physician's go-to for treating insomnia? Do you think that their go-to is medication, or do you think their go-to is behavioral intervention? And usually I have people shout it out. But I will tell you that right now, the physician go-to is still prescribing medication. However, what do you think, and that's kind of a leading question, what do you think has shown to be the most effective at treating insomnia? It is not the medication, it is actually the behavioral health strategies. So let's spend some time, the last part of my talk, about the last 10 minutes. I want to talk to you about the strategies that have been shown to be helpful in improving insomnia and helping our patients sleep better. So the first host that I want to go over is that sleep hygiene. How do we create better patterns around our sleep? The first one is to create a regular sleep schedule. And when I say this, I mean we go to bed at the same time and we wake up at the same time so that it gets our brain in the pattern of when do we fall asleep and when do we wake up. And this isn't just for Monday through Friday. The misnomer is, okay, I just need to do this on the work days when I need to get up and actually function or go to school or manage my children. This is actually 7 days a week. So even on the weekends, if we decide, okay, we don't have anything to do today, I'm going to sleep in today, we think that we're helping ourselves, but we're actually creating negative patterns and throwing off our sleep cycle. Only sleep when tired. So we do a really good job, our brain does a really good job at making connections with our behavior patterns. And if we are in a routine of getting into our bed when we're scrolling on our phone, watching TV, talking for hours with somebody, we are telling our brain that bed is not only for sleep. And we want to create that pattern that when we go to bed, we fall asleep. So if you're tossing and turning, we should be getting out of bed. No clock watching. If we're standing there and laying there and we're watching the clock every 5, 10 minutes, every 30 minutes, I want you getting out of bed because you're not ready to go to sleep yet. Again, this kind of parallels with that. Bed is for sleeping only. You are allowed to have sex in your bed. I still want you being intimate with your partner. However, again, we're trying to create that association that bed means sleep, not doing other things. Avoid caffeine, alcohol, and nicotine prior to bed. The recommendation is actually 4 to 6 hours before bed. We should not be consuming any of these. I know for many of us, we do drink alcohol, and it might help us initially fall asleep, but it actually ensures a very disrupted sleep pattern. And so they say 4 to 6 hours before we go to bed, we should try not to consume any of these. Minimize naps. This is a big one with my patients, especially during radiation treatment. So there are some therapies that make us tired, right? And we might even say, I want you taking a nap. But what I want you to do is I want you to minimize the time that you're napping. We should not be napping for longer than 30 minutes. Anywhere longer than 30 minutes, our body goes into a deep sleep and it's harder to arouse us. And when we do wake up, we have that continued feeling of exhaustion, drowsiness that we just can't snap out of. So if we're going to nap, again, during certain periods, I'm okay with napping, but try to set an alarm and make sure we are not going over that 30 minutes so we never fall into that true deep sleep. Incorporate relaxing sleep rituals. When we are getting ready for bed, trying not to do things that are stimulating our body and our brain. So instead of watching things that are going to stimulate us, a lot of light, playing a game of charades with our family, things that are going to get us up and excited, I want you decompressing. I want you slowing down. I want you relaxing, taking a nice warm bath, stretching, practicing some relaxation breathing, even drinking that calming tea. Make sure it's decaf, not caffeine, but anything that can soothe us and get our body into a relaxation state before we go to sleep. Exercising daily has been shown to be very good with helping us sleep at night. And then also creating a restful sleep environment. So obviously we don't want any bright lights on. We want low dim lights. They've shown in the research that actually a little bit of a colder room with nice fluffy warm blankets is beneficial. Some people benefit from wearing an eye mask because it does get rid of any light that is in the room, or even having a very soft fan on sometimes is helpful. And then the last thing I want to talk about is truly the tried and true standard of care for for insomnia, excuse me. It is called cognitive behavioral therapy for insomnia. CBTI is what you'll hear it referred to. This is in the literature and in the research, the frontline treatment for insomnia. It's recommended by both the American College of Physicians and the American Academy of Sleep Medicine. It is a non-medication approach. It helps with different educational, behavioral, and cognitive aspects to sleeping better. The best part about this intervention is that it is short. It is 6 sessions of counseling that help us sleep better. It is very well evidenced. It has been shown to be beneficial in healthy populations and a whole host of medical populations, including stroke and brain injury and other cancer populations. It helps with sleep quality. It helps shorten the time that we lie down to actually fall asleep. And it helps with extending the duration of our sleep. But up until recently, it had actually never been studied in our patients with brain tumors and shown to be beneficial. So that's exactly what Live Now did. A few years ago, we received a small pilot grant from the NRG Oncology, and we trialed CBTI in our patients with glioma. We wanted to see, A, is this safe? B, will our patients enroll? Do they think that this is something they need? And also, is it helpful? Is it beneficial? Would they recommend it? Should we move forward with investigating this intervention? And is it reducing their insomnia? So that is exactly what we did. We had 44 patients enroll in this small trial. We did show it to be safe. We had two adverse events, they call them, so two incidences of something that happened in the trial. Two of our patients did have a seizure while undergoing the intervention. During consultation with their medical team, these seizures were not any more than they had been occurring before the intervention, so they were not ruled to be a result of the intervention. So it was safe. We found that it was feasible. Of our patients that screened, 98% enrolled in our trial, and we were able to collect all the data procedures that we had in place for before the intervention, after the intervention, and then even a long-term follow-up. More importantly, 97% of our patients reported benefit from this intervention, and 94% said they would recommend it to others. And I just want to share another result, which I found to be just incredible. At baseline, 26 of our 44 patients hit that clinically significant threshold for insomnia. So they had severe sleep disturbance. 6 weeks later, none of our patients met that threshold for insomnia again. So it was a brief 6 weeks, and we were able to completely reverse their insomnia symptoms. We saw large improvements not only in this insomnia severity, but also in their sleep quality and reduced daytime fatigue. So this gave us the thumbs up that this seemed to be a good intervention and that we were headed in the right direction for helping our patients' sleep disturbance. So we actually right now have a small randomized control trial open for enrollment to try to move this research forward so that we can change the standard of care for our brain tumor patients, and our physicians can stop putting on more medicine and instead recommend cognitive behavioral therapy. So we have, like I said, we have an open trial right now. We are seeking 60 participants to go through this intervention. Now it is and I wanted to explain this so that you're aware of, if you're interested, what you're signing up for. This is a randomized control trial, meaning half of the participants actually receive the intervention and half are in the control group, because we need to compare, is this intervention improving the insomnia symptoms compared to not having the intervention? And so for 30 of the participants, you'll have data collection at baseline before the intervention. You'll get the 6 weeks of the intervention. Then you'll have data collection right after, and then again at follow-up. For the other 30, you'll go through the 3 data collection time points, but you won't actually get the intervention until the very end. After the follow-up data collection, we send you all of the materials, the manual, the whole intervention, so that you can go through it on your own. Again, it is how the trials are designed. But everyone will get the materials. It's just whether you get it up front or you get it at the end. What I want people to know on this call, because I know we are spread everywhere, is that this is a 6-week telehealth intervention. So we are recruiting nationwide. If you live in the US, then you can be potentially eligible for this trial. Everything is done via Zoom. You get on once a week with about 5 to 6 other glioma patients and your interventionist, and you go through the CBTI sessions together for 6 weeks via Zoom. So if you're interested, we are opening right now for our 4th group. We have 31 slots still available. Please email us or call us. Let us know you're interested, and my research coordinator, Mary, will reach out to you. And so in summary, to wrap it up, and I think, I did really good on time. Patients with glioma experience a whole host of negative sequelae, including ongoing fatigue and sleep disturbance. And this interlinked and interrelated vulnerability impacts our patients' daily functioning, and currently, as far as I see it, is not being assessed or treated appropriately. But there are effective strategies and interventions which can be helpful to our patients that do not include adding more medicine to their regimen. And our preliminary results at Live Now suggest that our patients with glioma can participate and are benefiting from behavioral health interventions, including CBTI. Sign up today. Thank you. I really appreciate you guys coming. I hope that you have learned a little bit more about why the sleep problems happen in our patients and what we can do about them. Some strategies and techniques that you can take tonight to try to adjust those regimens around and those behaviors around your maladaptive sleep, and also an intervention that is very, very successful in other populations, and we're hopefully proving that it will also become standard of care in our patients with glioma. And I will stop now and open it up to questions. Feel free to email me if you guys have anything you want to discuss offline. I'm happy to chat with you anytime.
Thank you so much. And I will stop the recording so that people